Good afternoon, everybody. Uh, I'm here to present a case that's not been discussed so far, which is quite different from what we've been discussing so far. So far, we've been discussing about clinical trials that involved use of drugs for pregnancy-related research. But now, in this presentation, I'm presenting. I wanted to discuss about a community-based lifestyle intervention trial that has been done in Kerala with the aim of reducing the risk of reducing the incidence of type 2 diabetes mellitus among individuals who are at high risk for developing diabetes. India has got the second largest number of individuals living with type 2 diabetes mellitus next to China. And in India, the southernmost state of Kerala has got the highest prevalence rate among all Indian states, with prevalence ranging from 9 to 20% in few populations. And we have got strong evidence from large efficacy trials, which proves that the risk of developing type 2 diabetes mellitus can be reduced by 60% following lifestyle changes. Gestational diabetes or high blood sugar in pregnancy is increasing worldwide, and if you look into the GDM prevalence in India, overall prevalence is 16.5%, with the highest prevalence reported in the southern state of Tamil Nadu with 17.8%, and the lowest being reported from Jammu, which is the northern part of India, with 3.8% prevalence. GDM has been studied. GDM has been found to have both long-term and short-term health risk for pregnant women, the fetus, and the child's future. There is strong evidence which finds association for the pregnant women with gestational diabetes to have gestational hypertension, to have preeclampsia, and higher risk for type 2 diabetes mellitus in the future. And also, for the child of a pregnant woman with gestational diabetes mellitus, there is higher likelihood of having a macrosomic baby, to have neonatal complications and birth defects. If you look into the child as such, studies have shown that the child born to a mother with gestational diabetes has a higher likelihood of childhood obesity and glucose intolerance in early childhood. And there is limited evidence which states that a girl child born to a pregnant woman with gestational diabetes has a higher likelihood of developing gestational diabetes by herself, and which gives evidence of transgenerational cycle of diabetes begets diabetes. The case study that we are going to discuss now is a cluster randomized controlled trial of a lifestyle intervention program that compared lifestyle intervention with no intervention. And the aim was to estimate the effectiveness of a culturally adapted lifestyle intervention in reducing the incidence of type 2 diabetes mellitus among individuals who are at high risk for developing diabetes. So the sample was selected at two stages. The first stage was that individuals were identified to be high risk based on an Indian diabetic risk score, which assesses the risk based on 4 parameters. That's age, family history of diabetes, physical activity, and waist circumference. And the ones who are classified as high risk were again we had to undergo oral glucose tolerance test to rule out whether they are diabetic. And the individuals who were either normoglycemic, having impaired fasting glucose, or impaired glucose tolerance were finally enrolled into the trial. There were a number of exclusion criteria from participating in this trial. The important ones are prior diagnosis of type 2 diabetes mellitus, myocardial infarction, heart failure, stroke, cancer, epilepsy, arthritis or dementia, current use of medications that's known to affect glucose tolerance, antipsychotic drugs, and pregnancy. So no reason was cited for excluding pregnant women in this particular trial, but I presume the possible reasons for exclusion could be, the first one could be that as per the ethical guidelines for biomedical research on human participants by the Indian Council of Medical Research, pregnant women are considered a special group that need precautions, and maybe that could be the reason that the principal investigators would wanted to exclude pregnant women, as all special group participants are excluded. There's a strong possibility of community attributing any complication that arise due to pregnancy to the trial, because trials or research is viewed suspicious in settings like India. And there's also a higher risk of loss to follow-up because this is a prospective trial, and the loss to follow-up is higher due to the cultural practice of transient migration of pregnant women to their mother's house for delivery. And the fourth possible reason could be that the diabetic risk score that's used has got this waist circumference component, which will vary during the course of pregnancy. So if they were to be included into the trial, a different diabetic risk score should have been used for the trial. So there are two ethical concerns that's been found in this study. The first one being looking into the favorable benefit-harm ratio. Participation of these pregnant women in this trial would have facilitated better health outcomes for the woman, fetus, and future child, looking into the long-term and short-term effect of gestational diabetes on the pregnant woman, child, and the future generations. And this, if they had participated in the trial, it could have contributed to a better understanding of short and long-term effects of lifestyle modification on pregnant women. And since they were excluded, they were deprived of the benefits of screening for high-risk status and subsequent involvement in the lifestyle modification intervention. And if we really look into the exclusion as a research, whether it affects the primary research outcome, it's the presence of risk factors and the high-risk status that leads to gestational diabetes and not being pregnant. So primary research outcome of the study is not going to be affected if they were included. Looking into the concern from fair inclusion-exclusion criteria, they should have been eligible for inclusion in the trial, and there are reasonable alternatives to exclusion. Like if the same Indian diabetic risk score is used for identifying high risk and low high risk, we could have limited enrolling pregnant women until first trimester of pregnancy, when till first trimester we don't expect change in waist circumference, and based on the risk at that stage, we could have enrolled them into the trial. Or we could have adopted a screening tool that's valid for pregnant women, or we could have screened for the high-risk status and given an opportunity to make an informed decision about research participation after weighing the benefit and the risk of mother and fetus by being in this trial. And we could have excluded, legitimate exclusion could have been restricted to pregnant women with high blood glucose levels suggestive of gestational diabetes as per the standard criteria at the time of enrollment. But there are a few community perspective and experiences regarding pregnancy that has to be considered when one thinks of including pregnant women in lifestyle intervention, which is especially a community-based lifestyle intervention trial. 4 lifestyle interventions that lower the risk for gestational diabetes are smoking cessation, regular physical activity, healthy body weight, and a healthy diet. Tobacco use is very low among women in Kerala. But in Kerala, it's widely believed that pregnant women should consume a high-calorie, energy-dense food to meet the needs of the growing fetus, and the pregnant women. And it's believed that any form of physical activity would result in loss of pregnancy. So that's a common myth and taboo that exists in the community, which increases the risk of pregnant women in developing gestational diabetes or diabetes thereafter. But however, the participation in this trial on adapted lifestyle intervention could have helped them challenge these myths and taboos by initially engaging with the community and addressing the other barriers. So my commentary and recommendations for future research is that since most NCDs have onset in the womb and it's highly influenced by the environmental exposure, unjustified exclusion of pregnant women from the trials with no foreseeable harm would actually compromise the benefit that the pregnant women, the fetus, and the subsequent generations would get. And it also limits exploration and advancement of research on future disease prevention in the population at large. So it's important that we empower the community and pregnant women and address the taboos and myths associated with pregnancy and enable them to weigh the benefit and the risk by participating in the trial. And it's very difficult to include pregnant women with no visible health problem. And this will have to be considered when making a policy in this regard. A recommendation for the research funding organization and ethical review boards would be to insist on a justification when they exclude pregnant women from research, and that we develop policies and recommendations that would actually prevent pregnant women from being part of trials like this, which has no foreseeable harm. Okay, and these are the references. I would like to thank the Global Forum of Bioethics and Research and Professor Francois for reviewing my case study. Thank you.